Hey, welcome back. It's Dr. Suchard again, this time with a video about carbon monoxide. The objectives for this topic are that when you're finished with the video and studying any related course materials, you should be able to name at least 3 sources of carbon monoxide exposure, outline the signs, symptoms, and abnormal lab results seen with carbon monoxide poisoning, identify the antidote for CO poisoning, which is an absurdly easy objective here, but an area of intense ongoing research and controversy, and be able to explain the rationale for hyperbaric oxygen therapy. When carbon-containing material burns and is completely oxidized, it releases carbon dioxide, but some lesser amount of carbon monoxide is also produced as a byproduct of incomplete combustion. There are many potential sources for carbon monoxide exposure in and around the home, such as from fireplaces, space heaters, water heaters, other natural gas-powered appliances, and automobile exhaust. Unrecognized blockage of normal exhaust flow or ventilation can allow carbon monoxide levels to build up and potentially cause poisoning. Another common but intentional source of CO exposure comes from tobacco smoking. Smokers can have carboxyhemoglobin levels above 10%, although of course this will vary depending upon how recently they smoked. But even in non-smokers, there's a baseline carboxyhemoglobin level of around 1%, since small amounts of CO are produced during heme catabolism. The primary way CO interferes with normal physiologic processes is by binding avidly to hemoglobin in our red blood cells, thereby decreasing our oxygen carrying capacity. CO competes with oxygen for binding to heme, and it binds about 250 times more avidly than oxygen. So it doesn't take very high ambient CO levels to result in significant increases in the carboxyhemoglobin concentration. The graph here on the right shows the oxygen-hemoglobin dissociation curve that you've learned about in physiology. In the absence of external CO exposure, when carboxyhemoglobin levels are virtually zero, you see a sigmoidal or S-shaped curve demonstrating cooperativity between the 4 hemoglobin subunits, which allows easier unloading of oxygen from hemoglobin in the peripheral tissues. However, in the presence of, say, 50% carboxyhemoglobin, we see a few changes to the curve. First, it plateaus at a lower total oxygen content since half of the oxygen carrying capacity is taken up by carbon monoxide instead. And we also see a hyperbolic shaped curve without the cooperativity normally seen, making it harder to unload the reduced amount of carried oxygen in the peripheral tissues. With significant CO exposure, then, the patient is functionally anemic since they can only deliver limited oxygen through the circulatory system. Carbon monoxide poisoning causes a spectrum of illness depending on the carboxyhemoglobin level and duration of exposure. The higher the carboxyhemoglobin level, the worse the signs and symptoms of cellular hypoxia. At lower levels, you can see headache, nausea, and vomiting, which are non-specific to CO poisoning and very easy to misdiagnose as coming from another cause. Even if a whole family presented with these same symptoms, it could be ascribed, for instance, to a benign viral illness being shared in the household. Here we see the ranges of carboxyhemoglobin levels that roughly correspond with which signs and symptoms. Milder cases, like the headache and vomiting just described in that hypothetical family, will have levels up to about 20%, while immediately life-threatening issues can occur with carboxyhemoglobin levels close to 50%. Moving on now to some lab findings with CO poisoning. Since carbon monoxide is taking the place of oxygen on hemoglobin, you would hope that the low oxygen saturation could be easily detectable, say with pulse oximetry, a non-invasive test performed so commonly that oxygen saturation has basically become another vital sign. Pulse oximeters work by shining light through a part of the body and measuring how much was absorbed by the tissue, commonly on the fingertip. Unfortunately, the oxygen saturation reported by pulse oximeters is typically falsely elevated with CO poisoning, which falsely reassures the clinician to think that the patient is okay, but they're not. And this is because standard pulse oximeters misinterpret carboxyhemoglobin as oxyhemoglobin. However, if you directly measured the carboxyhemoglobin levels from blood samples, which is a bit more invasive, you would get reliable results. When considering gases dissolved in the blood, some clinicians seem to believe you need an arterial sample, which is even more invasive than venous, simply because arterial blood gas measurement is commonly done when considering dissolved carbon dioxide and oxygen levels in sicker patients. But if the only clinical question was to determine the carboxyhemoglobin level, a less invasive venous blood sample works just fine. Standard pulse oximeters are simple spectrophotometers. They differentiate oxyhemoglobin from deoxyhemoglobin by measuring the absorbance of 2 wavelengths, One is red with a wavelength of 660 nanometers, and the other is near infrared with a wavelength of 940 nanometers. The graph here shows the differences in light absorbance between oxyhemoglobin and deoxyhemoglobin. The oxyhemoglobin absorbs very little of the red light, which is why it looks redder than deoxyhemoglobin, but the relative situation is reversed in the near infrared range. So we measure the absorbance at two wavelengths at the same time. This is a simultaneous equations problem you should remember from algebra. We need two simultaneous equations to solve for two variables, namely the amount of both oxyhemoglobin and deoxyhemoglobin. And to do that requires measurement of the absorbance of two wavelengths. However, standard pulse oximeters make the assumption that all of the hemoglobin is either oxyhemoglobin or deoxyhemoglobin. Sometimes, though, dyshemoglobinemias are present, such as in CO poisoning or with methemoglobinemia. Oxyhemoglobin and carboxyhemoglobin have very similar light absorbance at 660 nanometers, so a standard pulse oximeter, which assumes that all absorbance is due either to oxyhemoglobin or deoxyhemoglobin, doesn't even recognize that carboxyhemoglobin can be present, and since it is colored more like oxyhemoglobin than deoxyhemoglobin, the pulse oximeter assumes that it is oxyhemoglobin and reports a falsely reassuring O2 saturation. So, how closely red is carboxyhemoglobin to oxyhemoglobin? In fact, you could say that carboxyhemoglobin is even redder, more brightly red than oxyhemoglobin. This slide shows a demonstration with myoglobin, which is a similar heme-containing, oxygen-binding molecule that's found in muscle. On the left we see a perfectly good steak. It's fine to eat, but it looks a bit dark. If we expose that steak to carbon monoxide, forming carboxymyoglobin, it turns very bright red and appears fresher and more attractive. Exposing red meat to carbon monoxide is a common commercial practice, but you don't need to worry, the amount of CO in the meat is way too small to cause any problems. This same redder than red or cherry red discoloration can be seen in CO poisoning, but it is usually not apparent unless the carboxyhemoglobin levels are so high that the case is fatal or near fatal. The photo here shows a fatal case of carbon monoxide poisoning, which shows cherry red lividity. Lividity refers to the fact that after death, when vascular smooth muscle tone disappears, the blood pools by gravity in the parts of the body closest to the ground and fills dilated capillary beds. Typically, post-mortem lividity is cyanotic because it's caused by deoxyhemoglobin. This carbon monoxide victim was lying on their back, so we see the cherry red lividity very well here on the right flank, while the upper central back and buttocks are pale because they were against the ground and the body weight compressed the blood out of the vessels in those areas. So we've seen that the standard pulse oximeters don't account for the presence of carboxyhemoglobin or, for that matter, methemoglobin. Coximetry is needed to differentiate more hemoglobin variants using the same spectrophotometric methods. The number of hemoglobin variants you can differentiate is still equal to the number of wavelengths used. And if we use 4 different wavelengths, we can measure oxyhemoglobin, deoxyhemoglobin, carboxyhemoglobin, and methemoglobin. Here we see both a benchtop coximeter, as used in clinical laboratories, as well as a handheld portable coximeter. The handheld version is produced by Massimo, a biotechnology company based in the UC Irvine Research Park near the medical school. In addition to competing with oxygen for binding to hemoglobin, carbon monoxide has other mechanisms of toxicity. Carbon monoxide also competes with oxygen at other proteins, enzymes, and coenzymes, including inhibition of cytochrome C oxidase in the mitochondria, the site where oxygen is consumed in the electron transport chain. Thus, CO poisoning will both reduce oxygen delivery, making the patient functionally anemic, and it will poison the mitochondria, inhibiting complex 4, also called cytochrome C oxidase, the enzyme at the end of the electron transport chain that uses oxygen as the final electron acceptor. The electron transport chain is blocked, oxygen utilization decreases, and ATP production through oxidative phosphorylation stops. Both of these actions, reducing oxygen delivery and reduced oxygen utilization, result in the same kind of cellular and biochemical effects as being hypoxic. So carbon monoxide poisoning causes this cellular hypoxia, resulting in a shift from predominantly aerobic to anaerobic metabolism. Instead of glucose being metabolized to pyruvate, then to acetyl-CoA and fueling the Krebs cycle, the glucose goes to pyruvate and then to lactate. Lactate can accumulate, and we see an elevation in the serum anion gap. At the same time, the serum bicarbonate levels decrease, which is essentially the definition of a metabolic acidosis. All patients, pretty much regardless of what's making them sick, should receive appropriate supportive and symptomatic care, and that holds true for carbon monoxide poisoning too. However, the treatment, basically the antidote for carbon monoxide, is oxygen. We've seen that CO competes with oxygen, and the reverse is true as well. And the more oxygen you can use, the better, and the faster the carboxyhemoglobin levels will fall. Providing close to 100% oxygen, as through a non-rebreather face mask, is rapidly available. The question, however, is whether even more oxygen, hyperbaric oxygen, is better than that. In this graph, we see how quickly carboxyhemoglobin levels decrease with oxygen therapy. The red line shows the decrease in carboxyhemoglobin for a patient breathing normal air, which is 21% oxygen. The half-life of carboxyhemoglobin here is about 5 hours. The blue line is what happens with 100% oxygen at a normal 1 atmosphere of pressure. That's 5 times more oxygen, and the half-life is reduced by a factor of 5, down to about 1 hour. The green line is a patient treated with hyperbaric oxygen, here at 2.5 atmospheres of pressure. And this reduces the half-life by about a factor of 2.5, down to under half an hour. What you need to keep in mind, though, is that carboxyhemoglobin levels and the reduction in oxygen carrying capacity are only rough markers of total carbon monoxide poisoning. The amount of carbon monoxide in the blood does not represent the total body burden, nor the amount of CO causing injury in other tissues. There's often a considerable delay in getting hyperbaric therapy started. The patient will often need to be transferred because few hospitals have the necessary equipment, and in the meantime, the patient will be receiving 100% oxygen. So by the time they start hyperbaric oxygen, several or many hours later, their carboxyhemoglobin levels may be 0, and yet they can still benefit from that therapy, because carboxyhemoglobin levels are only a marker of CO toxicity. You don't stop oxygen therapy just because the carboxyhemoglobin level reaches 0. Hyperbaric oxygen, or HBO therapy, is administered in chambers that can be pressurized up to about 3 atmospheres with 100% oxygen. The control panel and the chamber itself can often resemble a submarine, and the treatments in the chamber are also called dives, as if the people inside are diving underwater to higher pressure zones. Here we see a multi-place chamber, which is big enough for multiple patients and sicker patients who may need to be accompanied by medical staff or equipment. Hyperbaric monoplace chambers also exist, but they most commonly are used for other indications in non-poisoned stable patients who don't need any fancy equipment or caregivers in with them. There is ongoing controversy whether hyperbaric oxygen is preferable to normobaric oxygen. There is some decent evidence that hyperbaric oxygen may reduce delayed neurologic sequelae of CO poisoning, and if you worked at a place that had HBO therapy available, it would be the way to go. But whether the potential benefits are real and whether they are big enough to outweigh the difficulties in transferring potentially unstable CO-poisoned patients lead many to justify keeping the patient where they are and giving them normobaric oxygen, usually for a couple of days. Not everybody with CO exposure necessarily needs HBO therapy, but some consensus about the indications has been reached. The table here is adapted from recommendations in Goldfrank's Toxicologic Emergencies. HBO is indicated for CO-exposed persons with neurologic findings, and most would dive pregnant women. Carbon monoxide binds even more avidly to fetal hemoglobin than to adult hemoglobin, and it's not feasible, of course, to test fetal blood, so just dive the mom. Most authors agree that anyone with a carboxyhemoglobin level above 40% should get HBO, and many suggest a more conservative threshold of 25%. HBO has mechanisms beyond simply competing with carbon monoxide and reducing the carboxyhemoglobin level. For instance, it will also displace carbon monoxide from myoglobin and other oxygen-binding enzymes and proteins in the body. Also, as you'll recall from physiology, the oxygen-carrying capacity of the blood has components both of the oxygen delivered by hemoglobin, but also oxygen gas dissolved in the liquid phase, which typically is only a very small part of the total. But with hyperbaric oxygen therapy, that portion becomes enough to meet a person's metabolic oxygen needs even in the absence of hemoglobin. More importantly, though, the delayed neurologic sequelae that can occur after significant CO poisoning are due to the neuroinflammation it can initiate, which does not end when the carbon monoxide is gone. Hyperbaric oxygen inhibits lipid peroxidation and also prevents neutrophils adhering to the CNS vascular endothelium, which both dampen the neuroinflammatory processes. And that's all we have about carbon monoxide. I'll be seeing you around.